right after delivery, they start really just pushing down on the abdomen hard and doing this massage. They call it a fundal massage, and it's very painful. Most women will tell you it was worse than the actual childbirth, the contractions for
Oh,
childbirth,
really? Wow.
it's a surprise to most people. They don't talk about that.
Hi, welcome back to Blood Talks. Today we have our special guest, Dr. Mason, here with me. She is one of our beloved pathologists that I had a pleasure working with. We have a few topics, and it's gonna be focusing on the OB patients and blood bank. We're gonna be talking a little bit about MTP as well. Dr. Mason, would you like to introduce yourself?
Sure. My name is Holly Mason. Went to college in University of Oregon. I got a bachelor's degree in linguistics and speech pathology, which has nothing to do with medicine. So once I left college and realized that I've always wanted to be a doctor, I went back to undergrad and got 2 years of math and science and went to Medical College of Virginia. After finishing there, I had to choose a specialty. So for residency, I picked pathology. I went into pathology and trained here in Los Angeles, did a fellowship in surgical pathology and a fellowship in transfusion medicine. And most of my career has been centered around transfusion medicine.
Yeah, and I think that's where I bother her a lot too with my blood bank questions. There's
It was
a
a
lot to
pleasure to have
learn.
my conversations with you.
Thank you. And I think one of the topic that we had talked about in the channels before was Bombay. It's something that we talk about a lot. It's like a textbook questions, but here our Dr. Mason, she actually have experienced it. Do you want to tell us, about it?
Sure. As I was telling Peach earlier, this is kind of a once in a career event to see a Bombay type. And that's what my mentor told me at the time that we encountered this one. I was a fellow. We had a woman come in who happened to be pregnant, actually. And she actually knew that she was a Bombay. So we were really lucky there. So it wasn't a surprise in the lab. They're like, what is this? But basically the reaction is that it looks like an O. But when you go to cross-match, nothing cross-matches, right? And so even O cells react against this, and it's a complete mismatch. And so if you're in our case, since we knew that this person had this diagnosis or history, we actually got a hold of some anti-H, and we were able to do the anti-H to confirm that yes, this is a Bombay type. So they have anti-A, anti-B, and anti-H, which covers A cells, AB cells, B cells, and O cells, because the O's still exhibit the H, which is the way I think of it as a signpost. So the H is like just a signpost. And then if you are an O, you don't have any sign on your signpost. And if you're an A, you have little A's on your signpost. And if you're a B, you have B's. And if you're an AB, you have a signpost with some B's and some A's, but all on the same cell. So in this case, it just reacts against everything. And so there's really no compatible donor for her unless you can find a Bombay donor, which is extremely rare because, as I said, it's a once in a career event to even find one of these. She did have a brother who was also Bombay type, but he wasn't. I don't think he was in the country. They were actually from the Middle East, which is another kind of misnomer. People think these are all from India, but they're not. They're different ethnic groups that exhibit this trait. In her case, what we did since she was pregnant is we did collect autologous blood and banked it and saved it for her just in case. The other thing that we did was we took a look at the isotype of the anti-H, because if the anti-H was and I'm blanking on the isotypes right now, but there's isotypes 1, 2, and 3 are really what you're looking at. One of the things that we did was we looked at the antibody itself that the mother was exhibiting, and first checked to see that it was indeed an IgG, which we know crosses a placenta. And then we looked at the isotype of the IgG. Predominantly, we're looking at isotypes 1, 2, and 3. This happened to be one of the isotypes that does not readily cross the placenta. So that was really good news for the baby and the mom, because this meant that it's not likely that this is going to cross over and affect the baby during the pregnancy and cause a problem there. So it's kind of like your IgMs that are, it could be incompatible, but not affecting the baby because it's not crossing over. So then the other thing we were worried about is with the mom, if she had any hemorrhage during the delivery itself. That was the main reason for having the autologous blood on hand. We were able to collect several units and freeze them and have them ready to go. She actually did not have any bleeding. She never needed a
Yes,
transfusion.
that's
It
very
was
nice.
really great. And we told her, "Don't get pregnant again. Please don't do that." She came back 2 years later pregnant.
But then you were able to save those unit, right? Like it's kind of stored for 10 years, or do you not?
I think we may have still had those frozen units, and she got through the second pregnancy just fine as well, so really lucked out there, but,
Yeah.
hope she doesn't ever have an accident.
And do you also like test the baby blood, or I guess you have to type the father and see what?
It would be extraordinarily rare for the father to be a Bombay as well, unless there's consanguinity, so I don't think that there was really any move to do any prenatal typing of the baby. After birth, I'm sure we did type the baby, but, I don't think anybody expected that, the baby would be Bombay.
Yeah, because I think it would be extremely rare.
Yes,
And
very,
then
very
with that case, they will guarantee to have a Bombay baby. Yeah, that's to be wow.
Yeah. Well, that's why if the, antibody did cross the placenta, that would have been really bad for the baby. And probably we would have had to auto-transfuse, the mom's blood periumbilically, but that's a good thing we didn't have to go there.
Yeah, I was about to ask, like, what if, like, if the mom has like one of the other isotopes? So then I guess you would have to monitor the baby even more closely
Yes. Yeah.
throughout the whole pregnancy.
It would make it very difficult to manage, for
Does
sure.
it also make the baby, like, I guess, due earlier, or like, or
I don't
not
think
really?
so. At the end of the last trimester in any of the antibody incompatibilities where the antibody is attacking the baby, it's usually in the last trimester that they get into trouble and, they become extremely anemic and hydropic because their heart rate is really high. So they're monitoring ultrasounds, transcranial Dopplers. If you're seeing like a really fast blood flow, that's an indication that the heart is working really hard to circulate the few cells that are available to carry oxygen. But it's almost always at the end. And typically, they may opt to deliver the baby early, but I don't think the baby would necessarily naturally come early. Sometimes it's easier to deal with what the baby's going through if they're on the outside, if they're far enough along.
Yeah. And that is also another reason why if you're ORH native female, so get your prenatal done and then get your
Yes.
RHIG early could kind of protect you like in the third trimester. When I was working in blood bank, one of like the things that we, I guess, scared of is when they call MTP and from OB unit. Can you give us some like insight? What happened, or like how like the doctors like determine like, oh, this patient is, I guess, high risk? Because I think a lot of the time they actually activated the MTP even before they went into the operation room.
Yeah. Yeah, there's certain times when, they know that the probability of hemorrhage is so great that having the blood right there in the room with them is important. So those times are usually when you know that you have a low-lying placenta that's actually covering uh, the cervix. So as the cervix starts to dilate and the baby's head is pushing down, it can actually push right through the placenta and cause a lot of hemorrhage right there. Um, and so the placenta is that low. There's really no place unless you're going to do a C-section. There's no way for the baby to avoid. They can do a C-section, but if it's on the anterior wall, it's the same issue. So if it's covering the anterior wall and low lying, then you're going to cut through the placenta in order to get to the baby, and so that's a really high risk for hemorrhage. So ultrasound is really important to make sure they know where the placenta is and how much danger there is from hemorrhage there. Also, if they have a patient who comes in and they're in distress and they've done an ultrasound and they see that there's been an abruption. An abruption is when the placenta actually tears away, either partially or fully, from the uterine wall, and a big blood clot forms behind it. So as soon as the baby is born, that big blood clot's going to evacuate, and that the mom can really get into a lot of trouble because they'll keep bleeding from that spot. So that can be very dangerous. Other situations are placenta accreta or percreta, and that's when the placenta, and they can tell this on ultrasound also, is actually growing through the muscular wall of the uterus. So it won't separate away without actually tearing into muscle. and blood
Uh,
vessels. And yeah, so that can be a really, really dangerous situation too. So generally those are C-sections if they can, but they do need to have that blood on standby because they know there's such a high possibility. That kind of takes me back though, because that's kind of how we've always approached, historically assessing a bleeding risk. So do they have a placenta that's at risk or is showing some physiological changes that make us worry? Or did the woman have a history of bleeding? So excessive bleeding with tooth extraction or bloody noses or a history of, say, carrier for hemophilia, anything like that. Women or anybody who'd had previous bleeding episode, especially with the pregnancy, those people would be high risk and we would kind of be more on alert with them, but really not worry too much about everybody else. And that's turned out to be not a good way to approach it. You really need to assume that anybody could have a hemorrhage because when we actually did studies and looked at the deaths due to obstetric hemorrhage, it was somewhere around 40 to 60% in across a bunch of different studies that showed that there was no pre-existing condition at all that would have given us any idea that this person was at high risk. We know that the older the mother is, the higher the risk is for hemorrhage, and African Americans have a higher risk for hemorrhage. There's a lot of reasons for that. It's very multifactorial, and not all of it is understood. Even African American women who are very healthy and go to all their prenatal appointments and do everything correctly still tend to have hemorrhages at a higher rate than most other groups. So we kind of know in some generalities who might be at risk, but there's a huge chunk of people who no idea. So we really need to be prepared for anybody to be in that situation. And one of the things that we came to, so I participated in this maternal California Maternal Quality Care Consortium. If you'd like to look that up on the internet and look up obstetric toolkit, it's a really great site. It's got a lot of information. It's all free. They will ask you to register with your email address, and that's only so they can update you whenever we have anything new that we'd like to tell you about. Like at the beginning, we recommended factor 8. That's no longer recommended. So it's good to keep up to date. So that's the only reason they're going to ask you for your email. But I participated in the initial toolkit rollout and in the subsequent revision. And the one thing that we found is that everybody, doctors, nurses, everybody in the room is very, very poor at estimating blood loss. So we actually did a couple of experiments where one of the nurses in our group actually took some red liquid and put it on several different types of pads and towels and things like that, and laid it out and asked people to estimate the blood loss. And they were wildly inaccurate across the board. It didn't matter if you were a seasoned OB or a brand new nurse, everybody was just terrible at it. And then to compound that, you've got a labor that's going on over at, sometimes days where the shifts are changing and different people are looking at it. And so the same people aren't seeing the cumulative blood loss. They're only seeing what happened when they were in the room. And the nurses are constantly cleaning things up and moving things away. So it's really easy to lose track and not realize how much somebody is bleeding. So they actually, in this experiment, they educated people on what different blood loss looked like. And then they got really good at estimating it. And then the following year, they had another fair and asked the same people the same questions, and they were terrible at it. So it didn't last long. So the biggest thing that we recommend is that you have a cumulative running tally of blood loss. And so there's a couple different ways you can do that. You can weigh blood-soaked lap pads and things like that and towels. And we had a formula that so you can calculate what the blood loss is. And so we have a quantitative blood loss instead of an estimated blood loss. And that was really big. And the other thing you could do is like under the buttocks drapes that actually have a catch basin, and it actually had a graduated measuring system. So you could just record that and then dump it and have it ready again. And one of the things that we saw that when we started having qualitative and quantitative measurements of the blood loss was that women were getting transfused unit or two early on instead of waiting until much later. And we dramatically reduced, it was really statistically significant how many people progressed to an obstetric hemorrhage. So it was kind of a strange thing because when we looked across the board, more women were getting transfused, and overall we were transfusing more to more people, but we didn't have as many obstetric hemorrhage, which is where it's really, really dangerous. So I think that was a win, and it was kind of an aha moment that actually what we need to do is make sure that these women get a little bit of blood early on to stop the kind of cascade that happens because they go into a coagulopathy. And once you've lost that battle, you get behind and you can't catch up.
Yeah, that's interesting because I think I guess my practice until now, I was thinking like it has to be necessary to transfuse. But now that you're saying like, it is probably medically necessity, but like how early is too
Right.
early? Right? I think that's really hard.
Yeah, and I think that that's what this taught us is that if we notice that the quantitative blood loss, and we actually have tables where it shows, when you get to this level, this is what you need to be thinking about. And it wasn't just blood; it was a lot of other things too, like uterotonics. It's a medication that kind of causes the uterus to contract and come down, because this is usually after the baby is out, getting the uterus to come back down. Because basically how the obstetric hemorrhage generally works is after the baby's born and the mother their uterus needs to contract back down to its normal size. So it goes from about this big to this big in a couple of days. So, and what happens when the muscles that are here, so you can think of the blood vessels are running in between the muscle fibers. And get my hands into the frame, as those muscles come down like that, they squeeze those blood vessels together and they seal them off. And so that's what's happening when that's going down like that. And that's why the nurse, if you've ever had a baby, they come in and they push on your belly and rub really hard because they're trying to stimulate that contraction. So that's really what we're trying to have happen. So a flaccid uterus, it'll just stay like that, and you're just bleeding and bleeding and bleeding, and the muscle fibers aren't doing their job to clamp that down. So there's a lot of other things in that toolkit that are more medical and surgical. And you try to do everything you can do to avoid a hysterectomy, which would be the ultimate.
So is that like I think the biting of the stomach?
Well, it might be, yeah. I'm not familiar with that practice, but I know that the tradition here in the U.S. That's the standard is right after delivery they start really just pushing down on the abdomen hard and doing this massage. They call it a fundal massage, and it's very painful. Most women will tell you it was worse than the actual childbirth, the contractions for
Oh,
childbirth.
really? Wow.
It's a surprise to most people. They don't talk about that, but that's really the goal. And so getting the early transfusions in is more about stopping the cascade into a coagulopathy. And then they're doing the other things at the same time. But we have thresholds. When you get to this much blood loss, you should be doing these things. And when you get to this much, there's other things to think about. And we have a threshold for when you call the blood bank and let them know you might need an MTP, stand by.
And then
And when
like
to call that.
when you said like, to get blood in early, you meant like whole blood, RBC, plasma? Because you wanted those clotting factor,
Right.
right? Like
Yeah,
so
that's another kind of a line that is, so one of the things that we revised in the second version of the hemorrhage toolkit was we said aim for 1-to-1 plasma and red cells, and it's really 6-to-6-to-1 because you're also adding a platelet for every 6 red cells and 6 plasmas. So you want to keep those as even as possible because the coagulation factors are in the plasma, right? So if you're just giving red cells, you're helping with the oxygen carrying capacity, but you're not helping with the clotting factors that are also leaving the body. But if you're just giving them a little bit of blood to begin with, you're only giving them red cells. So it's just packed red cells. And so the ratio is always off. So anybody who progresses all the way to obstetric hemorrhage, they've gotten a few red cells before the MTP was called. So that's kind of a delicate balance, knowing when it's time to shift from just giving the single units to like activating the massive transfusion protocol. So you're getting more of a whole blood
Rachel.
experience. Yeah. Yeah.
So would you say like whole blood, would a transfusion early on using whole blood would be
Well,
helpful?
it might. It's definitely something to explore. And I think that that's probably where some people are going to be going with this next. We have moved to whole blood in our trauma massive transfusions, and it's actually proving to be pretty successful. I think a lot of us were really skeptical and thinking, okay, you guys just want to go back to the olden days. But actually
Would it?
what happened
It
what's
was
happening, what swayed me on this is that you're actually decreasing the actual volume of what you're giving that's not blood. So there's a citrate anticoagulant in every unit of red cells and every unit of plasma. And the citrate is highly acidic. That's how and it also has the calcium scavenging. So that's how it works to anticoagulate blood. So you're giving basically an anticoagulant to somebody who's coagulopathic. You're giving an acid to somebody who's coagulopathic, and we know that acid drives coagulopathy even further into that zone, because you need to be in a good pH balance for the clotting factors to work. So if you can decrease the amount of citrate that you're giving somebody who's actually just bleeding out, that actually is really good to help stop that coagulation cascade spiral and the coagulopathy.
But during the MTP, aren't those being managed as well? Because, like, with like those chelate, like they have to watch out how many units you already putting in the patient. Because, like a lot of, I think, like especially like calcium, like when in one of those things that get chelate out, and then that would kind
Right.
of your all the
It's
clotting and all that.
really, yeah, it's one of those things you have to monitor really closely. You need to be looking at the acid balance, lactic acid, all that stuff. I don't know if you remember, you're too young probably, the old ER shows and the doctor shows when they had, big traumas, and they're working on them hard, and they're like, AMPA bicarb. They always would say that, AMPA bicarb. And bicarb is very alkaline, and well, it's a buffer really. And it's basically to bring up that acidity. But if your liver is working fine, it's doing the buffering already. So you don't need it unless you need it. And sometimes if you give bicarb, you can actually push somebody into being hyperalkalotic, which is also bad for the clotting cascades. So you really have to be watching that, looking at what their injuries are and where. This isn't so much of an issue with an obstetric patient because their liver should be pretty healthy, and we would usually know ahead of time if there's, they have a problem there too.
Going back a little bit, like I want to share the story when you were telling like the I guess doctor nurses have a I guess hard time of judging how much blood is actually lost. And actually that happened to me one time. So like I was working in a trauma blood bank, and then I have a doctor call, like frantically call, like screaming like I need unit, I need a blood right now. Like I was like, okay, so you're gonna activate MTP, or you're gonna prepare emergency uncrossmatched unit, send somebody to pick it up. And then he was like, no, I only want cross-matched blood only. I'm like, it
This
doesn't
is a
work
big
that way.
misunderstanding.
It doesn't work that way. Like I
Yeah.
was like, no, I'm going to manage the patient. I want cross-matched blood only. I'm like, okay, stop everything. Like I think we're like, okay, we'll have two people working on here. One going to start doing the cross-match, and another one going to do the blood type, like, and then another one actually preparing the
You should have a third person call your blood bank doctor to call him up and explain to him why he did. It's
We
safer for him to
actually
just.
steam. We have a resident in the back. Like this was at like the other hospital, and like we have a resident room in the back. So we were like, critical situation now. So then they like came out, and then so that's when we're like, okay, you do this, do this, and then like so we like kind of pause on the other patient because this one we kind of clinical. And then I think 5 minutes, 10 minutes go by, and we're like, okay, we're ready. We're ready. Like, okay, at that time we were waiting for the blood. We don't have blood on that patient to
Mm.
actually do the test. So we have all this, we prepared the reagent, we have the people stationed and waiting. Okay, no, okay, 5 minutes, we call back and be like, can you send down the tube? Like I need the type and screen. If you only want cross-matched blood, we have people here, like,
They
ready
haven't given you a
to
sample.
work on it. And then the doctor was like, no, you don't need patient blood. The patient is bleeding out. I need you to give the patient blood. Like, I
Well,
willing
that's
to
really
give you the
unfortunate.
blood. And I was like, I can't give you the blood if you wanted the cross-match blood. I can give you uncross-match blood right now. And then I think at the end, the resident took over, and the resident still can't calm the doctor down. So it went to like a transfusion medicine doctor at the
Hmm.
time. Um, Doctor actually has to call him to like, hey, calm down. I'm right here. And actually was like cursing to us. He was like, blood, like I need the blood. Then doctor has hey, like tell me what it is. So he was like, okay. And then he was like, no, you're not gonna need cross-match blood. Here, I giving it to you. And he actually goes to them himself, like to help.
That's good.
You
Yeah,
wait here. so that
That's the thing to do when you have somebody who is asking you for something that's completely unreasonable and you know the patient's life is in danger because they can't wait for this.
yeah,
Call a transfusion medicine physician and have them talk to them.
yeah.
I've
So
done that
then
many times.
the doctor like help is like, oh, I'm gonna go to you. So he went with the cooler with the blood so that he can. I think he want to assess the situation as well to know how critical it is, so that he can also actually call us and let us know what I guess going on and like how critical it is, how much blood do we should be prepared for the patients and all that.
Mhm.
But before he left, he was like, okay, prepare like three more cooler because it sounded like they kind of freaking out over there. So he's like, I don't know what it is, but I guess just have it prepare. So we did that. And
I've
then
actually had like the opposite happen a few times where
uh,
they call up and say, "Is my blood ready yet?" And then they say, "Well, it's going to be about 20 minutes for the cross match." And they say, "Okay." And they hang up. And then the patient expires and we get called for an RCA. And in the RCA, they said the blood bank wouldn't give us any blood. We had to wait 20 minutes and the patient bled out. And we're like, "You didn't tell us that. If you'd have told us that, we would have offered." So it was that experience that, at least in my blood bank, I counseled our CLSs to, when somebody called and asked if the blood was ready, that there's probably a reason why they want to know. Maybe it's just convenience, but we should always say, do you need something earlier than that? Do you need uncross-matched blood?
actually, I actually didn't know that was the reason. But when I was trained, I actually was trained to say that. Be like, you
Yeah,
can, oh, it's
because
about 20
we can't
minutes.
see it through the walls. We don't know what's happening over there. And if they say okay and hang up, we think it's okay.
But like, I actually never know why we have to ask that. But like during our training, we were trained to ask, like, okay, tell them like, oh, it's about 30 minutes. And then immediately follow up with, do you need it sooner than that? Or like, is it okay? Can you wait? Do you need something
Yeah.
now? Like, is it
That's the thing
emergency?
I always counsel when I give lectures to physicians. I always tell them there's always blood that I can give you that's relatively safe. I mean, it gets more and more safe the more work and more time we have to work on it, but we can get you safe blood immediately. So you never have to wait. If you need it, let us know and we'll get you something.
Yeah, we just need to know. Wow, but I think that is very very sad that it happened. But I guess for this one, it's I guess at least they call with urgency, right? So we kind of able to act on it. So now this like transfusion medicine doctor went there. He went there. He assessed the situation. He called back and he'd be like, "Stop the preparation." And then I was like, "Okay." But he didn't say anything, and then I was like, "Okay, he's coming back." So I guess we okay. He came back and he was like, "Yeah, the patient was bleeding excessively of egg else." And I'm like, "Okay." But I mean, the patient chart was urgent, so it like,
Yeah,
the patient chart it said like, gunshot wound, so that's
sounds
pretty
bad.
kinda yeah, but it was actually like, it's not through, it's not he didn't hit, it was like graze, like, so it's kinda
Oh,
basically a
okay.
cut. And
Okay.
then, I guess the clothing was soaking with fluid, then they I guess just visually, I guess that's kinda going back to, like, we're just looking at the clothing and then the
Yeah.
gauze, so it looked like a lot, but then after I guess when the doctor went there and able to look at it, the nurse was able to calculate it, estimated the actual loss, and yeah,
And it was probably off.
it was off, but, I mean, I'm glad that the patient is okay.
If you've ever dropped a test tube on the floor and broken it, that little bit of blood that's in that test tube looks like a murder scene. I don't know why blood looks like more than it is, but
Yes, because it's so thick also, I actually dropped a whole unit before.
wow,
I dropped a unit because
must have been a mess.
we were, like, trying to run back and forth. It's one of the MTP also that we have to prepare. So we were running back and forth. And then I carry like 6 units in my hand. So like three and three
Wow.
on each hands. And then like we're trying to run as fast as we can. And then we collide head on collision with the butt banger. And then I dropped the unit and then it was yeah, a
Yeah, that would be
murder
a
scene.
mess.
It looked like somebody like died.
Yeah.
And it takes so long to clean up. It's very thick.
Yeah.
It takes a lot. I think it took like maybe more than 30 minutes to get
Wow.
it like clean because we have to disinfect it as well. and like, making sure that it's kind of get all the little speck like everywhere that
Yeah.
it goes. So that's
Yeah.
it's a whole process. So yeah.
Luckily, it's been tested for all the bad diseases.
Yeah, that's true though. Like I think, and also, I was lucky because I have a change of clothes. So I just be like, I just change. I threw away my scrubs because I was like, I have blood on me, and I was like, okay, bring it home to clean.
Yeah.
Uh,
Not
so
worth
I
it.
just went to the bathroom and then I just changed it out. I just threw it away. 'Cause, yeah, it's not worth it at that point. It's not like a little dot here and there.
Yeah,
It was actually like, yeah.
I can imagine.
But yeah, so that was something. It was fun. Like I still like my times in blood bank. It's like, I mean,
It's an
a lot of
experience.
things, and it's pretty nice. Like you hear a lot of the things that you able to help and have a positive impact on the patient. So that was very really good and kind of make me happy every time I hear about it. I'm sure
Yeah. Yeah.
that's kind of how it is fulfill you as well. Actually, what is your most memorable, I guess, case, incident, or I don't know if
Oh,
anything you can recall?
oh, there's been so many things over there. That's one of the things I really love about this job and transfusion medicine especially, but, pathology in general. You will never, ever get bored in this field. Every day there's something new that, "Oh, that's never happened before. I haven't encountered that before." And you're pulling the books down and calling people up who are experts in the field. I had one patient who was an apheresis patient, and he was very atopic. He was allergic to a lot of different things, but he had TTP and we had to do a plasma exchange. So he had to have plasma. That's really the only treatment for TTP. You can't give them albumin. And he had told the intern in the when he was doing his history and physical that he was allergic to Benadryl. And the intern thought, "Oh, he's confused. He's thinking I get Benadryl when I have an allergic reaction, so he's confusing that he's allergic to Benadryl." So he didn't write it down. He was allergic to Benadryl. So when he started having hives and a shortness
Giving
of breath,
Benadryl?
we were giving Benadryl because we didn't see in his chart that he was allergic to Benadryl. We knew he was allergic to penicillin and, other things. So he kept getting worse. And so we gave more Benadryl and he got worse and we gave more Benadryl. And then we were giving steroids and then we intubated him and he was in the ICU. And when he woke up, he said, "Oh, yeah, I'm allergic to Benadryl. I told the guy." So that was fun. And then he was having allergic reactions to the plasma. And so it's like, what do you do? And luckily, I have a lot of friends in the field, and I called up a couple of experts, and Zantac is actually a good alpha blocker. So that's what we used was Zantac, which is normally for gastroesophageal reflux or heartburn, but it worked to get him
Interesting.
through his exchange transfusions.
But then how do you know when to switch? Like, do you like just kind of figure it out because keep getting Benadryl is not
But
working?
we thought that the allergic reaction was just that bad that it was over, it was the Benadryl couldn't catch it, but we were actually making it worse by giving Benadryl unknowingly. It wasn't until he woke up after the event and said, "Oh, yes, I am allergic to Benadryl." So I think the intern was like, "Well, you can't be allergic to Benadryl. That's what we give for allergies, but you can." So
I
that was
guess you
one.
won't forget. I think you'll forget about that one.
Yeah.
How many percentage of complications that we can actually prevent, do you think?
I think, especially with the OB patients, working together with the OB team and doing regular drills with them that was one thing that we really recommended in our toolkit. I don't think many people really do it, but I think it's really, if you do, it's really a good way to make sure that
Exercise.
when you're scared and when everything's happening fast, you know what to do because you've already done it a few times. Some hospitals are going to get a massive transfusion and an obstetric hemorrhage once every few years or even every 10 years because they're small, they're, remote, they don't have a big volume. But if you're at a really big medical center, especially with the big university medical centers, you're going to see it actually fairly often. So those centers are probably having more interaction with their OB teams and are more used to what you're supposed to do. But even so, with those, I had an experience not that long ago where the OB team decided to call a massive transfusion protocol and they couldn't figure out how to print a slip. And after the fact, I was like, all we really need is the name and medical record number and it's written down at least so that we can at least have that record and get it. So if you
On
can't,
it.
yeah, if it's 2 a.m. and nobody knows where in the computer to access the form or the slip or whatever, it's like we just talk to us. Just call us up and ask us what to do, and we'll help guide you through. We can't just hand you a box and not know where it's going because we're obligated legally to make sure that we know who got it. And so if there's ever a recall or whatever, we can go back and we that's actually something that is a problem often in trauma, because often it's like a car accident where there was multiple people involved and they call it massive transfusion on one person, but when it gets there, one of the other patients is actually in worse condition, so they just divert it to that person, and we think it's going to the other guy. And so, like,
Yeah.
after the fact, we can sort it out, but sometimes, it's hard to know, who did it go to, and if we switch to type specific, that could really be a problem.
Yeah,
So, yeah.
definitely.
But usually with the obstetric patients, we know ahead of time that, especially the ones who are definitely high risk. We also have a blood sample on them beforehand, unless they've had no prenatal work at all. That happens every now and then. But usually while they're in labor, we have time to do our type and screen and kind of be ready. The massive transfusion, that's like the first line, get it out there, get it to them quickly once they get to that point. But that gives us time to actually do type specific massive transfusion protocols. But I think obstetrics actually in a way is a little calmer because you have a lot more information before it
On the
happens.
patient.
Yeah, with the traumas they roll in, you don't have any history, you don't have a sample, you don't know anything about them. So
Yeah. So would you say that would be like I guess, the difference between the OB MTP versus like a regular MTP? Just like, at least with the OB, you most likely have something.
yeah, and hopefully that if they're communicating with you and giving you the heads up, because in our protocol, we do have, when you get to this threshold, it's time to alert the blood bank and let you make sure that they're ready for you, because this could turn into something bad. And hopefully it won't, but at least the blood bank is aware, and if it's 2 a.m. and there's two people working in the bank, that's not the time somebody goes to lunch. So because that happens, right? You got one person in there all by themselves in the middle of the night and they're dealing with this. And if they knew that there was a good possibility this was going to happen, that other person would have stayed with them. So those, like, communication is really huge. But typically they are communicating better. We do have more information. We have more time to think about what's going on because they're in labor for a long time. And usually you're getting a sense for how much blood they're losing.
So when that, like the MTP, is it like considered one patient, two patients, or like is the MTP, you're referring to like the mom or the baby?
It's really the mom. The babies usually do okay as far as that goes. So the hemorrhaging that's happening is really a mom issue. The baby, once they're delivered, if they have any other issues, it's usually unrelated. Typically, the hemorrhages, you do have cumulative blood loss through labor and things, but it's really after the baby's born that these big hemorrhages tend to happen, and that's because of the uterine atony and the placenta separated, and now those blood vessels aren't getting squeezed off and shut.
That's why, like, I guess you deliver 2 times, right, for each pregnancy?
What do you mean?
Like, cause like one, I don't know, maybe that's just like a
Oh,
Asian
delivering
thing.
the
Like,
placenta, you mean?
yeah, like you're
Yeah,
doing
yeah,
baby and you have to deliver like the placenta. So like
yeah,
for every pregnancy, there's 2 delivery.
yeah. Baby's out, and then the placenta. And the placenta usually stays attached to the wall and intact until the baby's out. They cut the cord, and then you have a few more contractions, and then the placenta separates, and then that's delivered as well.
It's like
So that's
naturally
typically
released.
where what's that?
Is it like naturally released, like with those, I guess,
Yeah,
contract?
yeah. Typically, that's how it happens. It just releases, and it seems to know it's no longer needed.
Like what happened, like if it doesn't like release? Like do
Right,
you
so if you have right, and that's a big issue too, and that's one of the things, as in anatomic pathology, whenever we get a placenta, the first thing we do is we look at the surface and, like, kinda put it back together a little bit, because sometimes they'll tear, but make sure that all of it is and accounted for, and if there's anything that's separated off, you can put it back and piece it all together like a jigsaw puzzle sometimes, and make sure that the whole thing is accounted for, because if any is retained, then it will cause bleeding, continued bleeding. If
Oh.
it's a small amount, it's usually a small amount of bleeding. It's not usually a big hemorrhage, but it can lead to hemorrhage. But more likely and more dangerous is it can cause an infection and sepsis. So that can be like a few days after birth. Mom is becoming septic, and they can actually die from that very easily. So in those cases, if the obstetrician will always look at the placenta as it's delivered, and they're doing the same thing, making sure that it's all intact. If it's not intact, they need to use a curette and go and remove anything that's left. And that should stop the bleeding as well.
And then like MTP on newborns or infants up to a year old, we do treat them a little differently than the adult MTP, right? Is it just the quantity of the blood that we are giving it to them?
Yeah, so typically we don't call it an MTP when it's an infant. So if they're rapidly losing blood, we would be transfusing in approximately what they're losing. And it is a much smaller amount. So a newborn baby can lose a cup, and that would be like life-threatening.
Life, yeah.
Yeah. So
It's
that's way less than a unit of blood. So we're not giving tons of blood like we do for an adult. With an adult, we're actually replacing adult size blood volume, including plasma. But with a baby, and it's really rare for a baby to be hemorrhaging unless there's some other underlying condition like hemophilia, and even that with that, I don't think that it's typically a big hemorrhage. It's usually like into the joints or possibly into the brain. So that's, it's not like an adult that's been shot, or a mother who her uterus isn't contracting down. So sometimes we have other reasons for needing to replace a baby's blood volume. So for babies who have like Rh disease of the newborn, or they have hyperbilirubinemia, which actually can cause deafness and blindness if it's high enough, we'll do an exchange transfusion on them. And typically we use 1 unit of blood. So it's 1 unit of O packed cells reconstituted with AB plasma, make basically a unit of whole blood that way. And then we transfuse that in as we're pulling blood off. So we're transfusing in the same amount that we're taking out. And so by the time you're finished with that unit, you've mostly replaced their entire blood volume, because it gets less and less efficient as you go, because towards the end, you're pulling off the unit you just transfused as much as probably more so than the baby's own blood. But you get most of that native blood out and the donor blood in that way.
Thank you. And then like I'm also curious, like, in I guess adult MTP, because that's kind of where I guess this next question lead to. What is your thoughts on like a low titer?
Yeah, actually, no, I'm one of the first people who did that. I didn't realize it at the time, but I talked it over with my blood bank supervisor at the time, and she thought it was the way to go, because we had a whole issue with we were developing our first massive transfusion protocol, and this wasn't all that long ago. I'm not that old. Where we didn't really have a massive transfusion protocol that not that long ago. We would just like issue blood as we could, and the thing that we were getting yelled at all the time is how come I don't have my plasma? Because the plasma has to thaw. The plasma is frozen when they call for blood. And so usually the plasma was lagging so far behind the red cells. And we also didn't really have that good of an understanding at that point of that 1-to-1 ratio, that we really need to get that plasma in early to make sure we get clotting factors on board. So when we started developing this massive transfusion protocol, and it was a lot based on work done in the military, and they were using whole blood there because they were on the battlefield, and they were basically drawing it from one soldier and transfusing it into the other without any processing or anything.
At least you have a patient to save, right? You
You're
can
right.
someone take them
It-
to a medical professional. So at least you have a person, a beating
yeah.
heart to save. And deal with all the complication later, whatever
It was
it
a
is.
real different situation that they were dealing with, but they were noticing that they were having more successes in certain areas. So they were really wanting that plasma in earlier and in the 1-to-1. So the only way we could manage to have a massive transfusion protocol, and I was in a level 1 trauma center that is the second largest one in our whole area, we needed to have plasma thawed out and ready to go. And we didn't have enough inventory to have AB plasma, because we know that would be okay for anybody, but we don't have that much of that. And it's usually we reserve that for the babies if we can. And if we use O plasma, that has anti-A and anti-B in it. So if, that doesn't make any sense, because most of our patients are, a good share of our patients are going to be A or B or AB. Luckily, most people are O, but it's not worth taking the risk. So we looked at it and we said, well, there's very few, our lowest population in our area of patients have group B. So if we have something that has anti-B in it, okay, we're taking a chance. But if we're using a low titer, A unit, and then we're making sure that we're minimizing that risk even a little more. So we've been doing that for decades, and it's worked just fine. And the one thing to remember too is that when you have a true massive transfusion protocol, that first box is probably on the floor by the second time the second box comes in. So it's gone through so fast, it didn't have time to do anything. So it's really and you're also transfusing in red blood cells, and you're completely changing their whole blood volume into group O red cells. So once you're into it and you've been, going through a few boxes, you're probably fine because you have mostly O cells on board, so that they're not going to react anyway. But the other thing about the plasma that's gives us the opportunity to mismatch a little bit, and we do it with platelets all the time, is that your endothelium, which is like football fields of area where you have small amounts of the A or B substance on those cells also. It's not just on your red cells. Oops, sorry. It's not only on your red cells, it's also on those. And so that acts as a sink. And when you get a finite number of anti-A or anti-B cells that come into your bloodstream, they get soaked up on that football field full of antigens, and they don't even bother the red cells because they get soaked up there right away.
Yeah, that's right. I guess I'm just curious, like with your extensive experience, how many boxes of MTP was the most that you, I
Oh,
guess, aware of?
oh wow. I'm not really sure because I think my staff would have told me when they got a really bad one, but I think probably like 7, 8 boxes. We've definitely gotten to there. We did have one. It was a motorcycle accident, and I think we were up to 7 boxes, and the surgeon said, I think it's time to try factor 7. Factor 7. And we did have some on hand. And actually, that's not recommended anymore, but we were, that was when we first tried that. And it actually was amazing because he immediately stopped bleeding. And the people in the blood bank thought, oh, well, he died because they gave 7 boxes of MTP, and then they called it and they didn't ask for any more. And they're like, well, the only time that ever happens is because the patient died. But usually they would ask for at least a few units even after stopping the MTP, but they didn't. And so when I saw the surgeon the next morning, I said, oh, I heard that our patient died that we used the factor 7 for. And he was like, what? I have to go up there. I just saw him. I was like, wait a minute, he didn't die last night? And he said, no, we gave him the factor 7 and he stopped bleeding. So it was a really amazing thing. So I went back to the blood bank and I'm like, you guys, he lived.
Wow. Okay, that's good. I guess my case was really bad. The one that I was a part of, the patient had 20 cooler.
Wow.
20
Wow.
cooler.
That's a lot.
Actually, the first 16 cooler was within 6 hours.
Wow. Wow,
And
that's
then,
incredible.
yeah.
I did work in a hospital where we did heart transplants and liver transplants, and the liver transplants would use actually, yeah, those would go up to 20. But it was interesting when we were in a blood shortage, they were able to use much less. I thought that was remarkable.
Sometimes actually I was questioning that too. Interesting. Because when I tell you that we have no blood to give it to you, you somehow manage to be okay. And then when we have blood, you're saying that you can't do without a unit more.
Yeah.
But yeah, that one, I remember it was a young firefighter who's in the duty kind of fall off the ladder.
Mm.
And that was really sad. So we were trying really hard to help him. Yeah. So using a lot. Was not a very good day that day. What do you think of some hospital practice transfusing low titer and some don't? Do you think it's, still in practice, or does it need to be adjusted, or kind of doesn't matter?
I think it's probably still in practice in a lot of places, especially the smaller hospitals. If you don't get a lot of massive transfusion protocols, it's having that inventory on hand and doing that extra work to make sure that you have low titer is not easy to keep up, especially if you know what your population is. If across the country, most people are O's and then A's and then B's, but different pockets of different communities might have a little bit different makeup where you might have a higher proportion of Bs. And so that might be something you would think about. But if you're in a typical setting or your patients from your area are predominantly O's and A's, I think it's probably safe to do that because of what we talked about before, the antigen sink that the endothelium provides. You can, once you get a sample, you can actually tailor it more to the patient. And if you're really using the blood fast, you're getting a lot of O's on board, and you're also losing a lot of what you just transfused in. So I think that it's relatively safe to do that. I think it's optimal and more ideal to make sure you have a low titer, but I think it's probably acceptable in a lot of situations, especially if you don't encounter MTPs that often.
So I guess it's if you have it, I guess it will be preferred. But if not, I guess
It
it's
always would make me very worried when I found out that our last MTP was a B. And I'm like, let's go look. But when we actually type his current blood type and find out that he's actually an O right now, he might have come in a B,
that's
but
just
right
like
now he's
the
not.
amount of
So
units that we
we
give.
kind of have a window of safety, but it lasts probably up to a week where you could continue that. But you can always transition to something that's more tailored to the patient himself.
Yeah, that's true. And then actually that just got me thinking, what about like, okay, in Asians we have, I guess,
Higher proportion
higher
of B.
B than like a higher proportion of B than compared to like Caucasians or other races. So then if I were, I guess the same practice in Thailand, then I guess the low titer would probably should be on hand, right? Because you would
Probably, yeah.
encounter more B patients.
Yeah, you probably would have an easier time keeping your bee inventory up as well.
True, actually. Yeah. I guess that was one of the reason why you need like a low titer A because the B is not as, I guess, common.
Yeah, and the other thing too is it's just a weird quirk of physiology. When you titer out the anti-A and anti-B, say in a red an O unit, the titer for A is going to be higher than the titer for B typically.
Okay.
So even if you're giving A blood to a B patient, usually that titer of B is low. So it's really easy to find those units. You don't have to go through lots of units titering them to find the right ones. Almost all of them already are. And so you're just verifying that.
Okay. Well, thank you so much. So that we talk a lot about, the OB cases. We talk a lot about like the MTP patients. Now we kind of have some questions that was submitted to us and we want your thought on it. So here's like I guess a complicated case. Let me kind of start off with this case scenario so that we kind of be on the same page. So we have a patient and a pregnant female. Yes, of course, female. Pregnant
We say
lady,
pregnant person nowadays.
yeah, but a pregnant person, come to the hospital. She's kind of stated that, she has not have any prenatal care, but actually was here to deliver.
Mm.
So she came in, we did the blood type, and the patient is type O, but the RH is question mark. So we did the week D, and it came up positive. So we give the patient's blood type positive. I mean, O positive to be the
Mhm.
patient's blood type. But sin is kind of question mark. So then we also sent this one out to be done by molecular to, like double check, like making sure that the patient's really is O pos. Kind of, we do this for all our patients just to be safe for the patients. And then I think the patients, when the results came back, the patient is actually or neck by molecular. So, but during between that time that we were waiting from the positive results that we were, I guess, saying that the patient has as a blood type, and then now that the reference lab saying that based on the molecular results, the patient is actually or neck. During that time period, we have given the patients a couple units of O positive. So, like would it I guess in this case or in like general in any case, if there's like a discrepancy in the RH type, would it be better? Would it be like, what would be your thoughts on like giving the patients as OPOS or NEC, like the RH part?
Yeah, so in general, my rule of thumb, and I think across the board, it's pretty much like this. If you only have your serologic typing, and that's all you have to rely on, you don't have time for the molecular because it takes weeks and she's giving birth right now. But you really have to just consider anybody who has a D variant or a weak D. We used to always call them weak Ds because of the reaction strength, but it's really they're D variants and there's many of them. We need to consider any patient who may be getting transfused as an Rh negative, just because we don't really know exactly what the D variant that they have is. if that's indeed what they have. If you're a blood donor, on the other hand, we're going to consider you an Rh positive. So we make sure we never give your blood to an Rh negative person and possibly expose them to D or even a partial D. So what makes a D variant is a variety of different things. So one thing is it can be just fewer molecules on the cell surface. So it's just like there's not enough antigen on the cell surface to pick up a big reaction. And so you get this small reaction, but they're perfectly normal Rh molecules and perfectly capable of sensitizing somebody. If that blood donor was given to an Rh negative person, they could definitely stimulate an antibody to Rh. But more typically what they are is truncated molecules. So the antigen has had some sort of a mutation at some point in its the building of the protein, and it's truncated at some point, but it can be truncated at a lot of different points. So some of the more antigenic epitopes may be present, may not be present. And so they've this molecular typing, they've really categorized in detail all these different variants that there are. And there's really so many, and they're discovering new ones all the time. But they're able to give a probability for whether or not this person would be able to make an anti-D. And then on top of all that, you can always have the possibility you can have an auto anti-D, but it's if you're having a weak D, it's probably because you're missing the epitope that now you're getting sensitized to. Even though you have partial molecule, you don't have the whole molecule, so you're seeing something that's foreign to you, and so you're making an antibody against it. So and until you have that molecular, I would definitely treat the patient as Rh negative and always give Rh negative until you have that information. And they usually give they give you the variant and tell you that this is highly likely to, that this person could be sensitized or not. And that's one of the ways we decide also for who gets Rh immune globulin. So, if in a situation like this where the patient is showing up and delivering and you never didn't have time to do anything, I would definitely give Rh immune globulin. I wouldn't hesitate because we want to cover them just in case. And it's not going to do any harm if the patient doesn't or is actually Rh positive. Yeah.
But if the patient come in early enough, would
Then we
you
have time to do that. Yeah.
would you still you wait for the molecular results to come back to give RHIG or still just to give RH?
It depends where we're at. So that typically they get a dose at 28 weeks and then another dose at birth. If we're right up on that 28 weeks, I would just go ahead and give it because the risk
No harm.
of giving it unnecessarily is really just the cost of it, and it's not even that expensive. Is going to do no harm if it wasn't needed. But if you miss it and the patient gets sensitized, then that's kind of a tragedy because now you've got a lot of medical ordeal ahead of you.
Would you still give it if the patients already have anti-D?
No, there's really no reason to do that. I was talking about the horses already escaped the barn. Shutting the door now is not going to help anything.
It's already done. The damage
It's
is
already
already
done. Yeah. It won't change anything.
Why do we do the screening before giving the RHIG?
Yeah. So typically we want to make sure before we give a dose of RhoGAM or RHIG, which is really the more proper way to say it. There's that RhoGAM is kind of like saying Kleenex or Q-tips, and when you should be saying tissues or swabs.
Yeah.
Because there are different brands. So before you give RHIG, we want to make sure that we know that patient's status. So there's a very small chance that during the pregnancy, there could have been a little bleed that was before the typical 28 weeks, where that's the most kind of the highest risk point. It could still happen ahead of that point, and the mother could have been sensitized and she may have started to develop an anti-D. In that case, we want to know that because that puts that pregnancy now at a much higher risk, and we're going to step up surveillance, and we're going to be doing much more in the way of ultrasounds and transcranial Dopplers and really monitoring the baby very, very carefully. If we give RhoGAM without checking, whenever we look at the antibody screen after that, it's going to show up as D positive, and we won't ever know if it's the D that we just gave her in a shot or was she developing that already beforehand. So we're kind of in the dark and blind. So I know at one of the hospitals I worked at, we had the obstetricians were complaining that the mothers would have to come in and get their Rh anti-D screening and go home and wait for the results and then come back and get their shots, and they were always negative, and they like, how come we have to do this? And our solution was to, since it's such a low risk and such a low probability that it's going to be positive to just go ahead and give their RhoGAM shot after they draw the sample to send to the blood bank for the screen. So we at least have that sample before the shot was given. They can get their shot. They make only one trip to the doctor's office and everybody's happy. So the rare possibility that they actually were becoming anti-D positive, then the RhoGAM shot isn't going to hurt anything. It's not going to help anything, but it also won't hurt. So it's just the cost of the vial, which is not even that much.
Do you manage the patients or the baby differently after that point if you already kind of know the patient is developed already an anti-D?
Yes. The first thing that the obstetrician is going to do is elevate the risk status of the baby. And so they're going to heighten their surveillance. They're going to have much more frequent appointments. So usually antenatal appointments are about a month apart. And then in the last month or so, they get to be a week apart, but they'll start going a week apart right away. They'll get more frequent ultrasounds. They may get amniocentesis to check for bilirubin. They will get transcranial Dopplers, which is a way for them to tell how fast the blood flow is, which is how fast the heart rate is. And the faster that is, it is an indicator of anemia because the heart's working really hard to push around those fewer blood cells.
Thank you. So it's like, anti-D. There's another antigen or I guess antibody. This is equally important or if not even more scarier than this is KEL.
Yes.
So if the mom has anti-KEL, what do we do at that point? Like, is there any anti-sera, kind of like RSIG that we can give to help the baby or anything?
Not really. The thing that's different about KEL or anti-K from all the other antibodies that can affect a pregnancy is that it acts in a really different way. So it crosses the placenta and starts attacking much earlier in the pregnancy, and it attacks not the mature red blood cells that are circulating, but it actually it homes in on the erythroid precursors in the bone marrow and the liver and where all the places where the baby is making new blood. So it basically damages those cells that are making red cells or turning into mature red cells. And so there won't, if you did a amniocentesis, there's not going to be hyperbilirubinemia. It's not going to show up that way. So you're not going to see a high bilirubin. You're not going to see icterus because those red cells never developed in order to be destroyed. So the other thing that's really scary about KEL is you don't have to see a rise in titer for it to be dangerous. So if you see that you definitely would follow the titer like you do with any other because, once it takes off, then you've got a problem. But with KEL, you act much earlier. If you detect it at all, you're going to put them immediately into a high risk category and do all that surveillance. If it needs to come to it, I guess the only really good treatment would be a periumbilical transfusion.
Like intrauterus transfusion?
Yeah. Yeah. So they would catheterize the umbilical cord intrauterine and transfuse blood that's KEL negative.
So do they have to cross match with the mom before?
Typically, yes. And we would give O blood, but it would definitely be KEL negative so that that blood would not get destroyed.
Mm.
And same with other antibodies too. If you get to the point where baby's in severe distress, very anemic, that's where you ultimately will end up. And you do all that surveillance to see if you ever get to that point, you have to intervene.
Yeah. But then, like, how do you monitor the baby? Because you were mentioning that it doesn't show up kind of like high Billy, like it's kind of show up differently in clinical wise for the cow.
Yeah, they're going to present with anemia. So what you're going to see is a transcranial Doppler with a high blood flow, high rate of flow, and you'll see high drops. And so there'll be those signs of anemia. But if you did an amniocentesis, it's not going to be icteric. It's not going to be with a high bilirubin.
Interesting. Wow, that was a lot. Thank you so much, Dr. Masons, for your time. Yeah, is there anything else you wanted to mention before we are concluded for today?
Well, I think the main thing that I like to always point out, both to the lab staff and to the hospital staff, is that people like me, transfusion medicine specialists, are in most of the larger hospitals, at least. And even the smaller hospitals usually have a consultant available. So if you ever have any questions on anything, call your transfusion medicine specialist from either side, the lab or the clinicians. And the other thing is to communicate with each other, because we don't have x-ray vision. We can't tell what's happening with that patient on the other side of the wall. And they don't have x-ray vision, and they really honestly don't understand what we do. As the anecdote you told me about somebody wanting cross-match positive or cross-match blood and hadn't given you a sample yet. So
Yeah.
it's really unfortunate that transfusion medicine, there's very, very little taught about it in medical school. And there's only the experience that people happen to pick up as residents. And it's kind of whatever happens randomly to happen in their
Mhm.
experience is what they know about. And they may not know what's really important. So
Yeah,
that's what
until
we're
like
here for.
later on, until they actually encounter it, and that's kind of
Yeah.
when all the panic and we kind of focusing on, I
Yeah.
guess, saving the life in front of us.
So, yeah, so calling somebody like me to talk to them a lot of times saves a lot of headache because I can walk them through and explain things. It's that's my job, and I never feel bad if somebody calls me even in the middle of the night.
Yes, I contest to that. Even on your vacation,
Yeah.
we actually, very thankful that we have you. We bother you on all sort of hours, any time of the day, any day in the calendar.
The lab is always so polite. They're always like, "I'm so sorry to call you." I'm like, "That's my job. That's what I'm here for." The doctors, on the other hand, they're never that polite.
Yes, because they're stressed because they're seeing, I guess, the patient like in dire need in front of them. And then like versus the lab, we know it's in the critical situations, but I guess in like it's visually right, like not in front of us. It's kind of the calm. It's a little like a level down, I guess.
Yeah.
So I'm pretty sure like they're like we all in like the same right mindset where like we're trying to save this patient just kind of from different angle.
And that's the other thing too, if you have good communication, then you understand that you're both on the same side of saving this patient instead of you're standing in my way of doing what I need.
Which could like it does happen sometimes. Like people don't
Yeah,
understand and be like,
exactly.
why are you doing this? You're standing in my way. I need the blood now. And I'm like,
Right.
I don't even know who's are you talking about? Give me the patient name and my number. Right? Sometimes.
Yeah,
So
I've
but
had that happen where people rush up to the window and they say, "Yeah, I need blood right now for the patient in the first bay in the trauma." And I'm like, "Well, who is it?" "No, they're the guy in bed one."
and like by the time you run up here to get that bed one, that maybe they change to a
Exactly.
different one because sometimes it get really bloody. They do change the patients or change it
And
to a more room that more equipped for that type of trauma too. So using
yeah,
the patient location is not the best.
it's a terrible yeah, it's a very bad idea. And what we usually do in those situations is the tech or the CLS takes the blood with them and gets the information and brings it back to the lab because you don't want to send them back and say I refuse to give you. It's like we're not the soup Nazis. We want to save the patient. So
Yeah,
if we can get the blood to them and then find out the right information and bring that back to the lab and then hopefully educate them in the quiet after it's all over with, that's a better way to handle it. But that's also problematic if you're the only one in the blood bank. You can't just leave. You might have to get
that's
somebody else.
true. Actually, in like a really small hospital, I know like in really small hospital, sometimes it does happen. You only have one person's, or especially like in graveyard shift. I had worked in smaller hospital before where like the whole lab we have two people on
Yeah,
grave this is for graveyard shift. So I mean the morning shift typically you have the most number of people. Evening shift
yeah.
you have less. Graveyard is like the least number of
And these things
people.
always happen in graveyard.
And yeah, the weirdest thing always happen. Anything can go wrong. It's somehow find ways to graveyard. And then this night there was only two people on the shift. And then, of course, the two, they do need to get lunch,
Yeah.
restroom break and stuff. And then if something happened, I don't know what it is. They always go when there's only one person.
Yeah, in that case, you can grab anybody, a lab assistant, a janitor, anybody could run down there and get that information, bring it back. Just tell them what you need.
Yeah. So anyways,
Hopefully a specimen while they're at it.
true. Actually, a lot of time I would have to call and be like, please give us specimen. Please give us specimen before the patients get replaced. And, we would have no idea after the patient get replaced. And then they'll be like, we can't give you the blood. We can't give you blood. And then, okay, I know the answer now, but like back then, okay, when I was thinking, I was like, you think the patient is bleeding out. Just pop the tube open, scoop it in, give that to me. But technically you can, right?
Well, yeah, I wouldn't advocate for that, but if it came to it, I'd do it.
Because I mean, like now I was like, oh yeah, like maybe it's not the patient, it could be the donors making, because like patient bleeded out a lot, and so
Yeah,
that's why you actually want to draw it from the patients, and also like the patient's ID. There's a lot of things going on. But when I
yeah.
first started out in trauma and under MTP, in my head I keep thinking like, just seeing the patient is dying, bleeding out, pop the tube open, scoop it in, and that's it.
Well, the citrate does, or the EDTA doesn't pour out.
Yeah.
Well, one of the things that, we were having that happen a lot for a while, it seemed like, and everybody was like, you don't understand, my patient's dying. I don't have time to. And so what I did was I asked to come speak to a grand rounds for the trauma surgery. And I went through the whole thing and explained what we do and why we need the sample and why we need it early in the whole MTP scenario, because otherwise we're working in the dark because we're just testing donor blood. And it was really interesting because I saw a lot of light bulbs going off over people's heads of all around the room. And they're like, oh, I didn't know that. So that's a really good way to handle that. If you're seeing it like as a persistent thing coming up, have your transfusion medicine person give a
Right.
talk, and they're always looking for somebody to do grand rounds. That they try to do it like weekly or monthly, most departments. So they really want speakers. So if you have an issue like that, and it's definitely one of those needs based things, it's a good way to get that point across. And
Yeah,
that's
absolutely.
also when I tell them, if you really, really need the blood right now, don't tell me it's okay that the cross match is 20 minutes.
Yeah, or like, is my cross match ready? Just say like, I need blood now. Do you have anything available for me? Like
Yeah.
some kind of urgency to let us
Yeah.
know that you
So
need it
I've coached
now.
them to have the right words to tell the blood bank, but also because it's a rotation system, and we're going to have a whole new crop of people in a few months. So it's a lot easier for me to coach the blood bank staff to ask.
So that we can gauge the sense of urgency. I never thought of that, like, oh no, like at the end they may not know that they can get
Yeah, they're
something
like, oh
sooner.
well, there's no blood available. There's nothing I can do, and so they go tell their attending, "I'm sorry that the blood bank says we can't have any blood." And it's like, no,
Mhm.
that's not actually what we said.
You can't have a cross match blood, but you can have some
Yeah,
relatively safe for the
yeah,
patient blood
right.
if you need
Yeah,
it.
we can always give you something that's pretty safe.
Yeah, even if we don't have anything, like we just think about it, we able to give you blood when we have no idea what type the patient is. So if you already give us a sample and we in the process of working on it, we definitely can give you something.
Yes.
So just let
Yeah,
us
and
know.
also the thing about taking uncrossmatched, I know a lot of them are really terrified about that because they think they're going to have a transfusion reaction and die in front of
Mhm.
them. And so the one thing that and when I give talks, but also when I call them up and like talk to the guy who wants the cross match blood only, but it's a trauma. That number one, pretty much everybody that comes into the ER in a trauma situation falls into the category of healthy everyday people, and of those people, only about 2% are going to have a red cell antibody. So 2%, that's 98% of the people that walk in your door or roll in your door are going to have an antibody. If you have a hospitalized patient who's needing an MTP, there's more like 4% in that population. So 96% of the people are not going to have any antibody. So if you need to jump straight to a massive transfusion or uncross-matched blood, it's a really, really good bet that there's not going to be anything that's going to happen. But if you're unlucky enough to have a patient who actually has an antibody, and you transfuse blood with that antigen in that matches, I guess there's a really good chance you're going to, like if it's a KEL, it's 90% of KEL of a patient's donors are not going to have KEL on it. So there's a really good chance you're not going to have any reaction. But even if you do have somebody who has a match antibody and an antigen that shows up, you're probably going to have a delayed reaction. And we'll know about it long before that's an issue. And we can counsel you and tell you what to do to be supportive. So it's really not a big deal to give uncrossmatched blood, and
Yeah.
we really scared people unnecessarily over the years.
Yeah. But then at the same time, we don't want to give them like over, I guess, confident that like, oh, Yeah, we can just keep giving uncrossmatched birth because it's still best to give crossmatch if it's, I guess, the time allow,
Yeah.
right?
Yeah.
Like if the time
And
allow.
this is one of the things where transfusion medicine doctors differ from transfusion medicine CLSs is you guys follow the rules very, very strictly. And we bend the rules and we know when to bend them. So we're really good at like, oh, okay, we can like do away with that. Don't worry about it.
That is when I said, per Dr. Mason.
Exactly. So, and I think we need that because if it wasn't for you, people would just be doing crazy things. So you guys have to enforce the rules and have to say this is the rules unless I've talked to the doctor who says, yes, you can go ahead and do that. But my job is to know when we can go ahead and bend or break those rules and when it's safe.
Well, that's
And
why
take
we
you
need
off the
you.
hook. So you're not making that decision. I'm making that decision.
That's why we need you, our beloved, transfusions expert here. So thank you so much, Dr. Mason, for joining us today. If you guys have any questions or after, listening to today and then you have more questions, please leave them below and we'll be sure to get back to you. Hopefully in the future, we can have Dr. Mason to come back again because, I having fun talking to you. And I think there are a lot more topics that we can talk about, like, transfusion reaction, for example. As always, your blood tell you the start of your health. Thanks for watching. Bye. Yay. Thank
Yay.
you.
Okay. That wasn't too bad.